I wanted to, first of all, welcome all of you to the Bill and Melinda Gates Foundation. My name is Dan Kress. I'm the Deputy Director in Integrated Delivery. I think, second of all, I want to thank all of you for taking time out of your very busy lives and all of the very important work you're doing to be with us today. I want to, I'll come back to that just a little bit. I also want to thank Jonathan Sugarman and his team at Qualis Healthcare for pulling together this extremely, what I think is going to be a really enriching and exciting day here for all of us. I know most of this, for many of you who've come here to share some of your lessons and experiences, this is all this is what you do in your day job, and it's all very familiar to you, but a lot of this is information that's going to be very new to many of us. And so we're extremely excited about that. We're also extremely excited we're going to be able to share some of those findings and with a much larger community of practitioners and policymakers in the low and middle income countries through some of the videotaping that we'll be doing throughout the day. I think that's going to be a great benefit. I really did want to sort of doubly thank all of the panelists and the presenters here who really, traveled far, have traveled, many of you have traveled here twice to have, there was a pre-meeting on this, and I met many of you at that pre-meeting. And I know that the amount of work and thought that's gone into this has really been extensive, and just to sort of express very profound and deep appreciation for all of the work you've done. It's from the day I spent with you previously, I was blown away, I think would be the safest way to describe it, at the amount of innovation and really rich experience that's there. And again, thank you so much for taking the time to come here and make this available to us. I also want to thank some of my other colleagues. We have colleagues from PHCPI, from some of our grantees, some of our China office and India office, and others who are here today, and thank a lot of them for making time to come here. I want to just talk a little bit about, why this event is taking place. And, because it may seem a little bit odd to many of you, it's sort of like, why are we focused on health systems and primary care and health systems and primary care in the U.S.? And so maybe, I think the answer is really in sort of two parts. One is about why the foundation's interested in primary healthcare and health systems and the evolution, and the other is the story about the U.S. experience. And really I'm going to sort of simplify just for the sake of exposition here, but there really was sort of having been at the foundation 12 and a half years since 2004, it sort of started in the late 2000, 1999 era. But so most of the foundation's evolution I've been part of, so I can sort of, I feel comfortable summarizing but perhaps not with all of the richness and detail, but just at a very high level. I think the first era was really around this idea of how can science and technology and innovation transform global health? And that focus in that first era was really largely, not exclusively, but was largely around the idea of new vaccines, diagnostics, and drugs to be able to kind of transform infectious diseases and global health conditions. I think and there was a lot of success in that, and I think really the second era was one where there was a huge amount of success on the technology side, but also some setbacks, and I think also an increasing sense that there were these challenges related to health systems, and you could have good technology, but you couldn't always actually deliver it, and so there was out of that sense of sort of frustration that there was that these challenges, the systems weren't able to kind of address a lot of the issues. They weren't able to make effective use of the technologies that we were developing. Grew a sense of, and in fact, one of the CEOs, earlier CEOs, Patty Stonecipher, used to call it the problem was the product pileup, which is we had lots of products in the pipeline in a basically kind of a clinical development pipeline, phase 1, phase 2, phase 3, but then we're kind of piling up because they would get to the system and then they would be thwarted. And so there was sort of the third era, which really grew out of that sense that the systems were inadequate in some ways and needed to be better addressed. And so there's a reflection that took place. It took place over quite a long period of time, actually, but then resulted in a recognition that the foundation needed to work more directly on systems. And specifically for us, the piece of the system that we focus most on at the foundation is the primary care system, because that's sort of the platform that delivers so much of the kind of interventions that the foundation has tended to prioritize: vaccines, drugs, et cetera. And so this focus on primary health care and systems is relatively new, and it's very much evolving. And so I think that's a little bit how we, again, glossing over a lot of important details that make the story even richer and more nuanced. But I think that's how I would sort of summarize it very briefly. I think the second question really is why focus on the U.S.? I think most of us generally view the U.S. primary healthcare system as somewhat maybe not a high performer. Let me put it that way. And really, a lot of this came from, we had an event at the foundation early on, one of our annual meetings, and we had invited Jonathan to come speak. And Jonathan spoke, related an incident or some experiences he had, which were kind of really very interesting. And he talked about how, he has been, several people from the delegations from the UK NHS, National Health Service, have reached out to his organization, Qualis, to kind of arrange study tours in the US of sort of, high-performing primary care systems. And I sort of asked him, Jonathan, why is that? Why would be you NHS come to learn about primary care in the U.S.? And that seems like that seems odd. And he said, well, the reality is that we don't really have a primary care system. What we have is an incredible patchwork of primary care systems, and therefore, in some instances, when you don't really have one system and you have thousands of systems, you can actually have quite a bit of variation. And so it was really this notion of variation, and I think that really sparked an idea that the learning and this understanding about what's happening on the frontier of innovation and performance in primary care, that would be super interesting. And so that's why we made this grant, and we sought a longer and stronger relationship with Jonathan and his team at Qualis. Because we felt like there was something there that we needed to learn, and many of you may be kind of wondering, well, U.S. low middle income country, what's the why that might seem too far of a reach? And I think the reality is that a lot of the countries we work in, India, for example, or Nigeria, even Ethiopia, the continuum of what population expectations are and what the capacity is actually quite varied. So you can have very rural, super low resource settings where just a health post that has almost a community health worker with some anti-malarial tablets, maybe some anti-diarrheal tablets, some amoxicillin or something like that. And then you can have Aravind Eye Institute in India, and so actually some of the innovations are, we think, across the spectrum will be interesting and relevant, because I think one of the things that we've always noted, and many of my colleagues who've done a lot of work with ministers of finance and ministers of health in developing countries, is that healthcare is oftentimes, and health reform is oftentimes aspirational in nature. People want to know what does good look like? What should I aim for? What can I build towards? So they want to know what's practical now, but they also want to know what can I really aspire to be, and how can I help my system evolve to a better and higher plane. So again, I'm just super excited about the day, and thank all of you for being here. And then Jonathan, I think I'm going to turn it back over to you.
So as Dan said, I'm Jonathan Sugarman. I'll be your moderator for the day. I'm the CEO of Qualis Health, which is a Seattle-based population health improvement organization. We've had the great privilege of leading this effort to kind of harvest lessons learned from U.S. primary care that may be of interest to those in the global community who are interested in transforming primary care, particularly in low and middle income countries. To do this, we assembled a team of experts from across the country in primary care. And I want to start with an expression of my gratitude to those folks for spending time. Dan mentioned a meeting that we had here a number of months ago. We came up with a very long list, actually, of, to use Dan's words, what does good look like? From that, we selected a number of examples to demonstrate some lessons about primary care. What I'd like to do over the next few minutes is kind of orient you to the day. So I'll start with the following. First, we'll talk a little bit about the objectives and structure of this symposium today. It's probably worthwhile thinking a little bit or talking a little bit just to make sure we're all on the same page about what we mean by primary care. After that, I will riff a little bit on Dan's comments about U.S. primary care and perhaps skip over it a little quickly because Dan made some of the points I was thinking of about kind of why would you look at U.S. primary care for examples that are of interest, particularly to low and middle income countries. And finally, I'll close with a little bit of preview of the day of what to expect to help you kind of orient yourselves as you go throughout the day. So what are our objectives for today? What does good look like? Well, one way to answer that is to look at some exemplary systems, many of which have been in the US and working well for a long time, who can demonstrate either an entire system that works quite well or some of the key elements of primary care that are done very well in particular systems. So the first section of things we're going to do is highlight some established US delivery systems, practices, procedures, processes. Now, primary care in the U.S. has been somewhat stable, I guess, up until maybe the last decade or so. It's been delivered in very much the same way that it had for many, many years, decades before that. But over the past few years, there have emerged a series of changes, exciting new models of primary care delivery, and we thought that we would highlight some of those models as well. Some of them are simply delivery system design, enhancements to the systems. Others are technological advances that really in many ways weren't feasible or possible. So we'll talk a little bit about those. Now, throughout the day, you'll hear about the importance, first of all, you'll hear that primary care is not a function delivered by a single person or a single individual. It's a complex function. And because of that, one needs a well-trained workforce to comprise effective primary care teams. So we're going to, throughout the day, be talking about various approaches to the development of the U.S. primary care workforce. In some ways, we're way behind other countries, but we may actually have some things that are of interest, both assuring initial professional competence, and as people move through their careers, you'll hear a little bit about some approaches to assessing continuing professional competence of a primary care workforce. Let me now spend a couple of minutes about what our objectives are not, just to get this off the table. We're not here to make the argument that a strong primary care system is fundamental to a well-functioning healthcare system. We're considering that to be axiomatic. It's another symposium. We can send you to the articles, but it's not our intent today to do that. It's also not supposed to be entirely a primer on everything that characterizes good primary care. Now, you'll see many examples of those things, but our intent is really to take examples from the US rather than to have a kind of academic framework for primary care. Although we would like to show you some models and approaches that may be easily applicable in low and middle income countries, that was really not the filter through which we looked at this. There may be some things that are out of reach for some environments, but even though the specific tactic might not be applicable, the thinking and strategies behind it may still inform some of your global transformation efforts. And finally, despite the predisposition that some of us might have to do that, we're really not going to talk a lot about the problems facing U.S. primary care today. It may come up a little bit, but when it does, it will typically be associated with some kind of solution or method that has overcome those barriers. So that's not what we're not trying to do. So how are we going to do it? Well, first we're going to start off with a presentation from a health system from the South Central Foundation in Alaska. And again, in response to Dan's kind of challenge, what does good look like? I think that's going to be a great way to start. First, there'll be a presentation, and then a conversation afterwards to draw out some more components that aren't in the presentation. That's going to be followed by a series of relatively brief, about 15-minute presentations, where we're going to have to kind of rapidly move through these. One of the struggles that we had in this is there's so many good examples that we tried to reach the right balance of breadth and depth. So that's not in the plenary sessions going to allow a lot of time for conversation. However, the plenary sessions will be followed by some breakout sessions, which will have much more time for interchange, questions, conversation, and queries. So we're going to move quickly through those. So there'll be 2 sets of plenaries and 2 breakouts throughout the day. Finally, we're going to have a reactor panel towards the end of the day to reflect on the implications of some of what you've heard earlier for the work that the foundation and its partners do in low and middle income countries. So quickly, just a few words about primary care. As most of you probably know, the kind of standard definition for primary care was established by the late Dr. Barbara Starfield, who talked about 4 pillars of primary care. First contact, continuous, comprehensive, and coordinated care. It's also a little more to that, that it's provided to populations that are not restricted to a single sex, a single disease, or a single organ system. So that's been kind of the widely accepted definition. And in fact, this is a slide from PHCPI. That's this question about what strong PHC really, or primary health care, really includes all those things. First contact, comprehensive, coordinated, continuous, so on and so forth. So this is linked very much, this definition of primary care is linked very much to the work that you've been doing at the foundation and through the Primary Health Care Performance Initiative. But let me just talk a little bit about what I think is a commonly held but actually very inaccurate belief about primary care, that it's simple care or basic care, when in fact it's really quite complex. The complexity derives actually from a number of things. Remember from the definition that it's undifferentiated circumstances. So it's not someone coming in with a broken arm or an eye that can't see. There's first the complexity of kind of differentiating from a concern that an individual has and picking out those things. So that's one part of the complexity. It's not focused on a single organ system or disease. So the breadth of knowledge that's required and the depth to deal with those things is significant. People in primary care often have a number of comorbid conditions, other illnesses. In the US, the average family doctor who has a brief visit sees a patient who has 3 complaints. If it's an elderly patient, they have around 3.6 complaints. If it's someone with diabetes, there may be 4.8 different conditions that they deal with, or 4.6 different complaints or problems that they have in a single visit. So this is a complex situation. And you could see this quote on the wall by Julio Frank, who, in addition to having been a former Gates Foundation Senior Fellow, was the former Minister of Health in Mexico and previously was the Dean at the Harvard School of Public Health. Primary care is not primitive care. I think that's something to keep in mind because not recognizing that can potentially result in workforce and designs and other things which really are not well suited to modern primary care. So here's another PHCPI chart, which I put up mostly for those of you who are familiar with it and working PHCPI. It's the measurement framework that, at least as of last July, you've been using to look at primary care systems in low and middle income countries. We're going to be focusing today a lot on primarily on the service delivery component, so the middle column here. And throughout the day, we may highlight kind of components of this column. These highlighting will be idiosyncratic because many of the presentations will cover the entire waterfront. But just if you want, those of you who are in PHCPI, want to look at what is it that you're measuring, what are the underlying functions that are going to be addressed during these presentations. You might be able to kind of orient yourself in these presentations and with these slides here. Now, you may have noticed that during this conversation so far, I've used 2 terms somewhat interchangeably. One term is primary care. The other is primary health care. Now, we're not going to dwell extensively on it today, but the terms actually have somewhat different meanings. In the US, we typically look at the left-hand side of this, the Starfield definition of primary care, and focus on that kind of process, the element of healthcare delivery that's first contact, accessible, continued, comprehensive, so on and so forth. Primary health care is a somewhat more expansive concept, which includes primary care, but it's more global in that it includes considerations about governance, politics, the greater role of the healthcare system in society. So the distinction may not really be that important today, but I do want, this actually comes from the World Health Organization publication. So just understand that people can mean different things when they're talking about primary care and primary health care. Today, we're going to kind of straddle both, and you'll hear examples of primary health care as well. Dan talked a little bit. I won't perseverate on this, but we have some issues with our healthcare system with regard to cost, access, and quality. One of the critical issues that we have is the imbalance between the primary care workforce and limited specialty workforce. So, for example, many OECD countries have 50% of physicians are family physicians. In the US, it's about 15%. Even when you add in other primary care specialties in the US, it's still maybe a third of physicians and other clinicians in the US are in primary care. So that's one of the key challenges, I think, with primary care in our system. And actually, as Dan said, we don't really have a system. We have a number of often disconnected, discontinuous models and systems. Some of them are federal government run for special populations, things like the Veterans Administration or the Indian Health Service. There are some large regional or kind of multi-region vertically integrated healthcare systems like Kaiser Permanente Group Health, which we'll hear from today. There's a national network of federally qualified health centers that are private organizations, but they are, in many ways, the federal government is a steward of those organizations, provides lots of funding for them, not as much as they should, but quite a bit. So it's not really a government organization, but there is a large network. You'll hear quite a bit about those today. There are academic health centers who deliver lots of primary care. We're going to hear from the Cambridge Health Alliance today, which is a flavor of that, connected with an academic center, but also independent in many ways as well. There are emerging models of primary care design, which are groups that are constituted quite differently than the traditional single specialty or multi-specialty, simply medical care groups. Patients come in, they get seen, they go home, and you don't really pay too much attention to them after that. But in fact, at least until fairly recently, most primary care in the US was delivered in pretty small settings. As of a few years ago, I think it's something like 7% of physicians, family physicians, worked in organizations of 11 physicians or more, and about half of primary care physicians were in offices of 1 or 2 doctors up until a few years ago. Now, there's been consolidation that's rapidly changing, but I think the history is something that's important to recognize, that these are, most primary care in the US has been delivered by small practices. So Dan talked a little bit about why look at the US. You know, that heterogeneity that I just showed has some disadvantages with regard to healthcare delivery and coordination, but has some advantages in terms of this conversation because there are lots of potential lessons for different kinds of models that can be designed. This is from an interesting monograph that was published a few years ago, looking at primary care systems across the globe and highlighting ones that really were great. And you can see in this list that among the 33 countries that they looked at, the US wasn't one of them. But despite that, there was a recognition that lots of ideas that had started in the US for healthcare system design or implementation really had filtered into those. So we think that some of the lessons that you're going to hear about today are going to be in the same category. You might not be able to take it and plug and play some of these activities, but they certainly have some relevance. So what are we going to hear about today? Let me just close by saying we'll first hear about some approaches to ensuring the health of large populations from some vertically integrated systems. Throughout the day, you're going to hear about various innovations at the point of care, the sharp edge where service is actually delivered with regard to care management, the importance of primary care teams, the integration of behavioral health into primary care, which turns out in the US has been a very, very critical function. We're going to hear a little bit about reducing barriers between the clinician's office and the community, how community health workers work in some settings in the US. We're going to also hear about some interesting adjuncts to primary care, some technological that are somewhat high-tech, some a little lower tech, but have tremendous capacity to connect specialty care, limited specialty care, with primary care. We're going to talk a little bit about delivery and financing a little bit later today, although that's not really the main focus. The focus of that's going to be which of the elements that you've seen in terms of delivery system design were either facilitated or prevented by some of our current financing systems. We'll talk a little bit, as I said before, about assessing and assuring professional competence. And finally, throughout the day, you'll hear a bit about the critical role, we think, of measurement and improvement strategies at the practice level in primary care in the United States.